compare them side by side, and I've even enlarged what has been was the standard, one would say the gold standard up until now. This I think would have to be seen as the new gold standard for seeing signals in the heart. Here you can see a very nice signal there. This is exactly the same tracing piggybacked into the BSG system. So a discrete improvement in the appreciation of detail in the electrical elements of the heart. So we're going to spend a few minutes just going through what the data has shown from a study that I was involved in, Andrew and Natalie was involved in. It's a multi-center study from around the United States. There was a smaller, non-randomized study before that. We won't discuss that tonight. We will go into this pure EP2O study, and we'll go through that more carefully, and there's another study planned for later this year. So this is the manuscript which was submitted. We got feedback today. Some minor revisions are required, but this almost certainly will be in press very soon. Data from this study. I'll summarize for those in the audience who don't think about these electrical principles a lot, but how do you really qualify sight or vision? It's really very difficult. You have to have some measures. If you put on glasses and you've been myopic all of this time, everything just looks clearer. But what is clear when it comes to the electrophysiology lab? So 5 principles here. The overall signal quality was looked at. Were we able to discern these low amplitude fragmented areas? Near field versus far field, the EPs will understand that. When we're pacing or cardioverting, how quickly does that recover to baseline? And what does the signal look like when we're ablating? These are all important fundamentals in the lab. There were 705 responses from 3 blinded EP specialists reviewing these signals and qualifying them as the same as, inferior, superior, and that's superior compared to that GE Pruka system that we've been using for years. This is a better way to just look at the results from the study. You can see that for 70 to 80% of the signals recorded during different cases, the signal quality, the discernment of signals, as judged by blinded reviewers, was superior. It was better. There was better signal quality. So that's overall signal quality, that's near field, far field, fragmented signals. And this was all arrhythmias combined. So 30 patients with atrial fibrillation, that was persistent, paroxysmal, 12 patients, VT, PVCs, and then also atrial flutter. It was across all of those arrhythmias that those characteristics were deemed to be superior with the BSG system. These are 2 I guess figures from the paper that was submitted, and I think it's difficult to appreciate from where you are, but for the EPs in the room, you can see the baseline with ablation versus the baseline with ablation with BSG. Much easier to discern signals. Another example, maybe not as good as the one I showed, but here you can see a His signal on BSG, and it's just very difficult to see on a regular system. So it's really just looking at things with a better, clearer lens so that we can see electrical activity. So in conclusion from that paper, and this, as I said, will be out, published soon, the intracardiac signals were statistically rated as superior compared to the conventional system which patients are which most labs are using now. So this was the case that I showed you earlier, and for the EPs in the room, you can see on the pentarray above the right superior pulmonary vein, all of this fragmented, low amplitude signal, not evident on our GE system, which I have really relied on. We even wanted to use a different system for a while. I said we were going to stay with Pruka because it is really the go-to standard. So for those in the room who don't see many EP labs, and also for the electrophysiologists, just to show how we're just changing our setup, just our workflow to place BioSig more central. If you can see things more clearly, you want that to be in the center of your screen. Here you can see our fluoroscopy, which is X-ray. This is intracardiac ultrasound. This is ultrasound in the heart, just the vitals. This is our mapping system, which you'll see in a second, where we recreate a 3D model that we work with. And this is our BioSig system adjacent, because I use this system to annotate. And for redo AFibs, for VTs, for atrial flutters, for congenitals, it's all about annotation. Where are the signals that are causing, that are driving the arrhythmia? So that's just another example for the electrophysiologist, how we've set up our system with BioSig, meaning the active live screen and then a review screen. This is the 3D model that we create during our ablation. We're looking at the back of the left atrium where atrial fibrillation originates. For the EPs in the room, the left-sided veins were isolated when we got in there. This was the flutter that you saw with that Pentaray catheter. You can see the Pentaray sitting up here. This is the annotation, and with just 2 ablations over here, we were able to get complete isolation in these veins. We would not have known that the flutter was requiring this narrow isthmus up here. It looked normal to us with the regular mapping system, and just ablation there. There was only one small little area, one small conducting isthmus that it was allowing that flutter to perpetuate, and we ended up with block because the rest of the veins had already been ablated with the prior ablation. Sorry for the non-electrophysiologist, but that's quite a profound impact with very little ablation. This is another map showing activation. This is electricity flowing through the heart. These are signals that are generated during the procedure. This is a scar from a mitral valve surgery that was performed on this patient. This was another flutter, and then ablation through here. Just making the point that everything for these redo atrial arrhythmias really is relying on careful annotation. All of those colors mean certain things to us electrophysiologists, and if you can see things better, you can annotate better. So in conclusion then, you can see electrical detail more clearly. I think even the non-EPs can see that, and it's a fundamental driver for outcomes. We'll discuss outcomes in a second. How do you integrate it into your practice? That's exactly how I've integrated into my practice. And then improved outcomes, what does that really mean? If you're able to see things better, the procedure should be shorter. If you're going to do less ablation because you can see better, it's going to be safer. Those are the 2 sort of fundamental issues. Is it going to be better in the long run? I think it has to be, and that's going to need more trials and more studies to bear that out. But if you can see better and you're doing less ablation, patients are going to do better in the long run, and that's the goal. So I'm going to stop there and happy to take any questions.